I'm going to go back on the record on case 251-401-132, State of Utah versus Sundwall. Counsel, anything we need to cover?
Yes, Judge. I apologize. I know this is not ideal, but we have a witness, Dr. West, who is only available today. We are a lot behind what we anticipated scheduling-wise, and so Mr. Williams has agreed to let us put him, if Your Honor is agreeable, let us put on Dr. West before the cross of Mark. Mark may, I'm not sure how long Mr. Williams has for him, but he may bleed a little bit into tomorrow, but Dr. West is unavailable any other day.
Certainly, Mr. Williams, are you okay with that?
Yes, Your Honor, we're happy to accommodate.
I can't tell you how much I appreciate the lines of communication staying open as far as witnesses and making things happen and trying to stay on schedule. So
We're trying.
yeah, that's just fine. Is he here right now?
He is, yeah.
Okay, let's bring the jury in then.
All rise, jury.
Thank you. Please be seated. Ladies and gentlemen, the jury, welcome back. We're going to take things a little bit out of order right now. The state's going to call a new witness, and we're going to have that witness testify, just based on scheduling, and these things happen in trial. It really doesn't matter what order witnesses are called. So we're going to hear from a new witness right now, and after that, then Mr. Williams will have a chance to cross-examine Mr. Farnsworth. Call your witness.
The state calls Dr. Christopher West.
Thank you. Please come forward, sir. Come on up here near the clerk. We'll get you sworn in.
Please raise your right hand. You do solemnly swear the testimony you shall give in the case now before the court will be the truth, the whole truth, and nothing but the truth, so help you God.
Yes. Come on up here and have a seat. Appreciate you being here. The only thing I ask is you keep that mic in front of you so we can all hear and we can make a good record.
Okay.
If you start to wander, I'll let you know.
Thank you.
Thank you. Counsel.
Thank you. If you could please state your name for the record.
Christopher Reed West,
What's your occupation?
orthopedic surgeon,
How long have you been an orthopedic surgeon?
5 years.
I want to go through briefly your education and training to become an orthopedic surgeon. What does that process look like?
After undergraduate, do 4 years of medical school, followed by a 5-year residency, followed by an optional year fellowship, with which most orthopedic surgeons do.
Did you do that?
Yes.
So if my math is right, that's 6 years training total?
6 years plus an additional year of a traveling fellowship abroad.
Okay, so 7 years total. Do you perform knee replacement surgeries as part of your practice?
Yes.
Where do you practice?
I practice at Tosh, the Orthopedic Specialty Hospital, and LDS Hospital.
Were you the orthopedic surgeon for Kacee Terry?
Yes.
Do you remember when you first began treating her?
Yes.
When was that?
That was at, I believe it was at the end of 2024, when I saw her in clinic for the first time.
The end, are we talking December or?
I believe it was late fall that we saw her for the first time.
Late fall. Did you end up performing a knee replacement on her?
Yes.
Do you remember when that happened?
That happened in the summer of 2025.
If I tell you that she died in August of 2024, does that help refresh your recollection of when that surgery would have been performed?
It does. I remember that it was around 2 months after we performed the surgery that I heard about her passing.
So that would put the surgery in the summer of 2024? Does that sound right?
No, the summer of 2025, I believe.
So, I'm sorry, if I tell you that she died in August of 2024.
That would make sense, that would be 2024.
Okay.
I'm sorry.
Thank you. Do you remember exactly when the knee surgery was, or the knee replacement was performed?
I apologize. I'll need a refresher on the date.
Would July 23rd, 2024 make sense to you?
That does make sense, yes. And so I would have met her initially, at the end of the previous year. So
Okay.
2023.
What's typical? How far in advance do you meet with a patient? And I know it might differ, but before you elect to perform a surgery?
Typically, if I'm seeing a new patient for the very first time, it depends on if they've undergone previous treatments for their knee arthritis most often. And if they already have undergone all previous non-operative therapies and it really feels to everyone like surgery is the next step, then usually that's going to be scheduled about 2 months in advance as long as there are no other extenuating circumstances.
Do you remember what, if any, condition Kacee had affecting her knees?
Kacee had end-stage osteoarthritis of the knee.
Do you remember how old she was when you met with her?
I believe she was 37 or 38.
Is that typical for a 37 or 38-year-old?
No, I would say of the population that I perform knee replacements on, it's probably less than 5% that are in that age category.
How do you diagnose this? Is this her telling you about pain, or is this something that you independently verify through other means?
Pain tips us off to a deeper investigation, which starts with x-rays, and that's how we make the diagnosis of the source of her pain.
So in her situation, her x-rays were consistent with, sorry, what did you say?
Osteoarthritis.
Osteoarthritis. Was that present in both knees?
It was.
Were they about the same level of that condition, or was one worse than the other?
One was worse than the other. The one that we treated was definitely a few steps along and was down to the bone-on-bone stage.
What does that mean if it's down to the bone-on-bone stage? You mentioned non-surgical treatment options may be something that you explore with the patient. Is that something you'd consider if it's bone-on-bone?
Yes. I would say the decision to proceed with surgery is based mostly on symptoms and failure of conservative means. Bone-on-bone refers to complete degradation of the cartilage. Arthritis is a disease of cartilage, and when that's completely worn down so there's no cartilage left, that colloquially gets referred to as bone-on-bone.
And that was the condition of one of Kacee's knees?
Yes.
Do you remember the condition of the other knee?
We rate severity of osteoarthritis on a scale, Kilgren-Lawrence, 1 to 4. I would have rated the treated knee that we performed surgery on as a grade 4. So that's why I say end stage. I would have said that her other knee was grade 2 to 3.
Are grades 4 and then 2 to 3 on the other knee, are those something that surgery may be appropriate for?
We generally, if we're just looking at x-rays, which the decision is based on more than just x-ray findings, but if we're typically looking at x-rays, often 1 to 2 grade is able to be treated non-operatively, where the symptoms are able to be controlled with non-operative means and often can avoid surgery. Grades 3 to 4 often cannot avoid surgery entirely, and we're often not able to achieve adequate pain relief without surgery.
And at least one of her knees was grade 4?
Yes.
And the other was 2 to 3?
Mm-hmm.
Do you remember what knee was replaced?
I believe it was her left knee that we replaced.
If I told you that it was the right?
If you told me it was the right, you may be correct. So I apologize.
No, you're okay. What's your process like when you meet with a patient to determine if they're a good candidate for knee replacement?
It typically involves a face-to-face conversation. I talk about their pain with them, how long they've had the pain, the characteristics of their pain, what are the treatments they have tried to help with their pain up to that point, including physical therapy, injections, medications. We review their x-rays together with them. And then I also review some social characteristics. I talk to them about where they live, who they live with, if they have a stable living situation, other aspects of their social health, smoking history, other substance abuse, other medical conditions that might affect recovery or safety of the surgery itself. And then we have a conversation about all the options that are available.
Okay. Do you remember having such a consultation with Kacee?
Yes.
Did she tell you that she had cancer?
No.
Did she tell you that she was born with only one kidney?
Yes.
Is that something that you would have been able to independently verify as part of your process?
Independently, without some direction from her, I probably would have picked that up in a review of her medical records prior to surgery. However, in the initial consultation, it likely would not have come up if she had not brought it up.
Is that something that you did verify, though, that she was only born with one kidney?
Yes.
Does that affect how you may go about your surgery with a knee replacement?
Not the surgery itself, but some of the medications that we prescribed post-surgery would have been scaled back a little bit. Not so much in light of her single kidney, but the fact that she had a history of chronic kidney disease. And so that warranted more caution with some of the medications, specifically nonsteroidal anti-inflammatory medications.
Okay, I'm going to get back to that in a second. You mentioned that in a consultation about whether a knee replacement is appropriate, you go through, I forget what you termed it, social aspects of a patient. You mentioned finding out who they live with, support system, things like that. Why is that important to determine before electing to perform a surgery?
I think during recovery after knee replacement, we're trying to make sure that the patient is going to be able to keep themselves clean, that they're going to be able to avoid falls. I think that necessitates a certain amount of minimal support. They're able to be fairly independent getting up and getting around the house, but making sure that they have family or friends or a support network that can respond to them if needed is important. And then for cleanliness, for infection prevention as well.
Did Kacee appear to have the needed support network to be an appropriate candidate for surgery?
Based on her description of her contacts that surrounded her, it sounded like she did have a stable enough support network to have a successful recovery.
As part of social issues that you talk about with the patient considering knee replacement, do you talk about mental health issues?
Yes.
Why is that important?
I think that can affect mostly patients' recovery process and their perception of pain and their ability to cope and do the necessary work together with physical therapy to get their motion back after a knee replacement. I think that depression and anxiety can often amplify the pain that patients can experience.
If somebody has severe depression or anxiety, does that affect whether you elect to perform surgery on them and something as serious as a knee replacement?
Sometimes. I would say most of the time, patients who I speak with depression and anxiety are already undergoing some form of treatment or counseling, and it is in a controlled enough state that it's safe to proceed. However, in extreme cases, I would refer to somebody to a behavioral health specialist prior to proceeding with scheduling the surgery. And I did not think that her case at the time meeting her warranted that type of a delay.
What types of things would you need to observe or hear about depression or anxiety that would give you pause about performing surgery? Like you said, that you may need to refer them to get that under control before surgery is appropriate.
I think that if I was witnessing an active mental health problem that clearly was not controlled patient had emotional reactions to the conversation we were having that were out of proportion to the conversation, or if there was significant concern that they might be, that their safety might be in jeopardy due to self-harm, that would be a concern, or if somebody was clearly actively hallucinating or having other mental health manifestations, then that would be a reason.
Did you see any of these problems with Kacee?
No.
What's recovery like for a knee replacement?
Typically, it's an outpatient surgery, which can mean either discharging the same day from surgery or discharging the next day within a 23-hour period. Typically, people are full weight bearing as tolerated. Typically require crutches or a walker for balance in the first week or two, often getting away from that by the time that we see them at their 2-week appointment to check the wound, make sure the wound is healing well. It involves pretty rigorous physical therapy, especially in that first month, where we want to see significant progress week by week in getting the motion back as the pain starts to get more under control and the swelling goes down. Usually by a month, things are feeling very under control and the motion is on track.
So when you're analyzing somebody's mental state before surgery, their motivation and ability to engage in physical therapy is a huge part of what you're assessing?
It is.
And why is that?
Because if they're not motivated or able or in a stable situation where they can participate with that physical therapy, then they probably will not get their motion back. And if that persists for a few months, then sometimes that can become a problem that will not resolve with time, and sometimes is a reason for consideration of revision surgeries in the future.
Did Kacee talk to you about having depression or anxiety in the past?
Yes.
What did she say about that?
She said that she told me that it had been an issue that she had dealt with for a very long time, but that she felt that it was in a stable state of control at that time, and that she was feeling like she was ready to get her life together in other ways as well. And that's why she was considering getting the knee taken care of.
Do you just rely on what a patient tells you about their own mental health, or do you make, I guess, other observations about how they're functioning?
We make other observations about how they're functioning. Compliance with non-operative treatments is a part of that, and I think that's a good clue as to whether their mental health is sufficient for them to follow the instructions that they'll be given post-operatively. And from what she told me in our initial discussion, it seemed that she had trialed all those non-operative means from a technical standpoint successfully, although it didn't yield the outcome that she had been looking for up to that point.
Did she present as stable and appropriate for surgery?
Yes.
Are you also taking into account just how a patient presents? You said that somebody having like active hallucinations obviously would not be a good candidate. What other things do you observe about them personally, if anything?
Overall cleanliness. I typically am observing their dentition as we're talking, and sometimes have them smile, like, we're assessing infection risk and, from that standpoint. So lots of physical characteristics. I always do a physical exam of the knee. I think smell, as a marker of personal hygiene as well, is something that factors into it a little bit. These are things that are not necessarily, well, they're very subjective tests, obviously, but they raise suspicion of markers of instability or lack of self-care. And then appropriate responses to questions as we move through the conversation.
Anything concerning about your discussions or meeting with Kacee in that regard?
Not in particular.
You found her appropriate for a knee replacement?
I did.
And I reminded you that happened on July 23rd, 2024. Does that sound right?
That does sound correct.
You mentioned that you can be outpatient usually. Do you remember if she had to stay longer than is typical?
She didn't stay longer than typical. She did, if I recall correctly, I believe that she did leave that same day, that evening. So she did well with physical, which means that she did well with physical therapy. She passed all their tests, and she was able to discharge within that outpatient window.
You kind of referenced the typical recovery process. I think that you talked about some follow-up appointments. What are the date markers of when you want to see a patient back after a knee replacement?
I see patients back at the 2-week mark, and then at the 6-week mark. If they're doing very well at the 6-week mark, then we may spread out the follow-ups till 1 year post-surgery. If there are still some things that we need to keep an eye on, then we'll see them at the 3-month mark as well.
Do you remember discussing with Kacee whether surgery on the second knee was considered or appropriate?
We did discuss it. It was, we decided to proceed with the first knee and see how the recovery went. And again, I think that her history of depression, even though it seems stable to me, was part of that consideration. We wanted to just make sure that the first recovery went well before we proceeded with the other side.
So you said that you like to see patients at the 2-week mark. Do you remember if you saw Kacee again after her surgery on July 23rd?
We did. My physician's assistant saw her and discussed her case with me, and I reviewed her x-rays.
Do you remember what day that would have been?
That would have been 2 weeks after the surgery.
If I tell you July 31st, does that sound about right?
That does sound right.
How was she, you reviewed her x-rays at the 2-week mark, how was she progressing?
She was progressing well. From a knee standpoint, there didn't appear to be any complications. The wound was healing well, no signs of infection. Her motion was starting off on the right foot. She was getting at least 0 to 90 degrees of motion, which for the 2-week mark was kind of the minimum that we wanted to see. So she was showing the progress that we felt was needed. The only concerning thing that we saw at her 2-week appointment was that I believe there was an ER visit in the interim between her discharge and her follow-up with us, but that was more related to her fluid status and kidneys than something specific to her knee.
Okay, I'm going to come back to that in a second, but at the 2-week mark, other than the ER visit that happened in between, you said that she was progressing as was expected or sufficient. What does that mean about what she must have been doing at home in recovery?
It means that she was motivated to do her home exercise program as was instructed to her by physical therapy before she discharged from the hospital. So it's generally a good sign that our feeling that she was an appropriate candidate was bearing out as time went on.
What does that home physical therapy regimen look like?
It typically involves making sure that you're getting up and walking every hour, and 5-10 minutes of walking is sufficient to the bathroom, to the kitchen. Make sure you're getting the blood pumping so you're preventing blood clots. Make sure you're breathing well so you're not having developing pneumonias. And then typically the range of motion exercises that physical therapy teaches them are pretty gentle in the first couple weeks, but typically patients are instructed to do that about 4 or 5 times per day.
Anything about Kacee's presentation at the 2-week follow-up appointment that made you concerned that she was not doing all of that correctly or appropriately?
No.
Her other knee, I think you said, was in the scale or grade a 2 to 3.
Mm-hmm.
She had expressed interest in replacing the other knee,
Yes.
and I believe you said that you were going to see how she was doing with healing at the 6-week mark before talking about that more seriously.
Correct.
If she had been progressing as normal at the 6-week mark, would you have deemed her a good candidate for that second knee replacement?
If she was showing if she was continuing to show good progress in her recovery and she was feeling that she was ready to proceed with that, then I would have agreed to putting her on the schedule.
What medications do you typically, well, that might be a bad question. What medications did you prescribe to Kacee after this surgery?
We prescribed what we typically prescribe, which is aspirin for blood clot prevention, typically 81 milligrams twice a day. We prescribe a stool softener to be taken as long as there's any narcotics on board, which we prescribed her 5 milligrams of oxycodone, which is what we typically prescribe to be taken every 4 to 6 hours as needed. We understood that that was on top of what she had already been taking. She had been working with, I can't remember if it was her PCP or a pain specialist that was prescribing it, but I think she was taking 10 milligrams of oxycodone per day for chronic pain. And so we're a little judicious on what we prescribe from an opioid standpoint, but felt it was safe to up that to 15 milligrams total.
And sorry to interrupt,
You're
do you up that because patients develop a tolerance for that, or what's the reason for that?
There is a tolerance that's developed, and typically people who are on chronic opioid dosing going into surgery will respond well to our typical dosing schedule on top of their baseline. And typically we prescribe that for the first 2 to 4 weeks, and then we hand that pain management back over to their pain specialist. So to finish your other question, so those are the medications that we prescribe, along with scheduled Tylenol, 1,000 milligrams every 6 hours.
Do you prescribe anything for nausea?
As needed.
Do you remember if you gave Kacee anything for nausea?
Not to my recollection.
Did you limit her ability to get refills on the oxycodone?
I don't recall ever, if she did request a refill, I don't recall saying no. We typically will prescribe 20 tablets, and about half of our patients at 2 weeks are not requesting a refill, and if they do, then that's something that we will do without too many barriers, if we feel like that's safe.
You don't remember either way whether Kacee requested that?
I don't remember if she requested a refill.
You mentioned an ER visit that happened in between surgery on the 23rd and her follow-up on the 31st. Were you made aware of why she went to the ER?
I believe she was having some fluid overload symptoms. I believe her swelling was a part of that, and she had concern of whether her excessive swelling had anything to do with her kidney function.
Could the two be related? I guess, could the knee replacement have led to fluid retention or I guess, that's that question. What did you say she went to the ER for? Something about fluids?
When I reviewed the records, I believe that the ER had said that she was presenting with a chief complaint of fluid management, fluid overload, because if the kidneys aren't working, then sometimes you can retain fluid inappropriately. They didn't find anything too concerning in the ER visit, and she was able to discharge home from there. And my interpretation of their testing and results, because her labs were all reviewed, were that she was probably experiencing normal postoperative swelling,
Okay.
which can be surprising for some people.
Are you aware if she was prescribed anything for nausea at the ER?
When I reviewed the records, I do believe Phenergan was on the list of what they administered to her. I don't know if they prescribed her anything to go home with, but I do know they administered Phenergan.
Does Phenergan have another name?
Reglan.
What's promethazine?
Promethazine is a generic form of that, yes.
You expected to see her back at the 6-week mark, I'm guessing.
Yes.
Did that happen?
No, it did not.
Why not?
At the time, I didn't know. Some people have scheduling conflicts, and if they see us at 7 weeks, 8 weeks after surgery, that's not atypical. We do like there to be at least one check-in. I learned through our own system of reporting of a death that occurred on one of my patients within 90 days, and that's how I learned of her death.
So that's something that your system tracks automatically?
Yes.
Were you surprised that a death had occurred in this case?
Yes.
Why were you surprised?
death within 90 days is a metric that's followed nationally, and as it should be, it's extremely rare.
When you heard that a death happened here, what did you do, if anything?
I reached out to contact numbers that were within her chart. I got a hold of her sister, and I wanted to talk to somebody primarily to offer my condolences. I had no idea what the cause of death was at that point, and I felt like it was appropriate to ask at that point what happened, and it sounded like there was still not a clear-cut answer, but I was made aware at that point that there was an investigation that was opening pertaining to her cause of death.
Were you made aware that suicide was being, I guess, considered at the time as a potential cause of death?
I was aware that that was probably going to be one of the potential causes explored.
How did you feel about that pertaining to Kacee?
It would be a very sobering realization to realize that one of my patients committed suicide so close to her surgery, and it would have made us go back and look with much scrutiny on our own decision-making process regarding the stability of her situation.
Did you do that here?
Yes.
Find anything that you should have raised your eyebrows that you had missed?
No.
Have you treated patients with suicidal ideation before?
Surgically?
Yes.
Not with active suicidal ideation, no.
Have you treated them not surgically, just as patients?
Yes.
And I guess what signs do they exhibit that you might be looking for in somebody that is looking to be a candidate for surgery?
Objection is when I'm going to see some foundation on this subject.
I guess in what setting have you worked with or treated patients with suicidal ideation?
In the clinic, treating osteoarthritis of the hip and knee.
And is that something that I think we've talked about that, you try to rule that out before you elect to perform surgery on these patients? Is that fair?
Yes, I'd say that our questioning doesn't often specifically go there unless we have other things in the conversation that make us think that there's some instability from a mental health standpoint.
This might sound like a silly and obvious question, but what is the purpose of a knee replacement surgery?
To improve the quality of life?
Is knee arthritis a terminal condition?
No.
Would you operate on somebody that you had determined to be medically unstable or near death?
No.
Would you operate on somebody that you considered to be suicidal?
No.
I don't have anything further.
Good afternoon. I don't know why I have to remind myself at this time of the day, but ask a few questions, obviously on the same subject. My name's Scott Williams. We've never met, right?
No.
Doctor, how much time total do you think you spent in person with Kacee Terry?
I probably spent about 45 minutes with her in her initial consultation.
And then the rest of the time, well, there was another time that you were with her. She was unconscious because you performed surgery on her knee, right?
I met her on the day of surgery prior to the surgery, and we probably had a 10-minute conversation at that time as well.
And it looked, don't think you put an L or you put a marker on the knee you're supposed to do the surgery on, right?
Yes.
And talk to him about, you okay, we're ready to go under.
Yes.
Tell him I had some surgery. So 45 minutes before you operated on her knee, and you never talked to her again afterwards, right?
Until the day of surgery, no. I did not. My team did.
Well, she came back for one post-op visit that a PA conducted, right?
Yes.
You did not see Kacee Terry.
Not after the surgery, no.
So by the time that you learned of her death, and as you had indicated, references to suicide and things like that, that I think you said you looked back over the protocol. I'll get to that in a minute. But at the time you learned that she had died, you had spent 45 minutes, maybe, with Kacee Terry.
I believe I spent 45 minutes, yes.
Yeah, well, is there some record that you ever made about the interview you did with her?
There's our clinical notes that records our conversation.
Have you reviewed those?
Yes.
So do you have them here?
No.
When did you last review them? I mean, we were off by a year on the knee surgery and we got the wrong knee. Well, when did you last look at your records?
I last looked at them last week.
And so in this 45 minutes that you're trying to assess Kacee Terry, among the things you did acknowledge was that it includes learning about maybe some mental health issues, right?
Mm-hmm.
Yes?
Yes.
Sorry, I needed audible. I'm not badgering you when I do that. What you learned from Kacee Terry, you learned what was basically, according to her, right, subjective.
Yes.
You never looked at any other records.
We did look at other records.
Did you have Dr. Masteller's records available to you, her primary care physician?
Yes, I did. So I did not review those personally, but my team, my clinical nurse, and my physician's assistant did review the primary care physician's records and did not see any contraindications to surgery at that time.
Well, let's talk about, we don't know what they saw, and in a court, we can't say what they said they saw. But someone else looked into records that included her primary care physician's records, is that
Yes.
right?
Yes.
So no one told you about suicidal ideation that she had made to Dr. Masteller.
Correct.
Would that have been interesting to you?
It would have been.
To learn that she had been referred out for mental health services because of suicidal ideation expressed to her primary care physician?
It definitely would have been concerning if that had been within the last few months. Yes.
Okay. Also, it sounds like you did know that she was being prescribed in what seems like an extraordinary amount of pain medication. She was being prescribed oxycodone, right? By Dr. Masteller.
She was being prescribed oxycodone by her primary care physician. I don't know if I agree that that's an extraordinary amount based on what I typically see.
How long was she on that with Dr. Masteller, that pain medication plan?
From my understanding, it had been years.
And were you privy to the actual amount that was being prescribed to her?
Based on my review of the records and my team's review of the records, it was about 10 milligrams, I believe.
180 counts, did you know that?
180 milligrams?
180 counts, 180 pills.
Oh, tablets.
Tablets.
I was not aware of what the quantities of tablets that were prescribed in a given fill of the medication.
Now, of course, a medication fill recommends what somebody should take, right?
How many are you saying
That's
that?
how much, what, it recommends a regimen with the medication.
Yes,
Of course, that can be abused, right?
correct.
Abused in opiate users, right?
Yes.
Did she tell you that she had been in any therapeutic circumstance seeking to address substance abuse?
In recent history, when I was talking to her, not to my recollection.
Did she tell you that she used benzodiazepines?
To my recollection, not on a regular basis.
She wasn't prescribed, as far as you could see, benzodiazepines, right?
If I had been aware that she had been prescribed benzodiazepines and she was taking that simultaneously with narcotics, I would have voiced significant concern with that.
And you certainly asked what a medical, what kind of regimen your patient is on in terms of medication, right?
Yes.
You also have the ability to look at their charts to find out, right?
Yes.
But other than the charts, it's up to them to tell you what their medications are if they're not on the prescription, right?
In fact, in many cases, the patient's reports of the medications that they are actually taking often bears more truth than the actual medical chart sometimes, which can be littered with not updated information.
And if she'd have told you she was using benzodiazepine, which Xanax is a benzodiazepine, right?
Yes.
Otherwise known as alprazolam,
Yes.
you would not have given her the opiates that you prescribed. Is that right?
I would not have recommended that she take those at the same time post-operatively, correct?
And when Kacee Terry came in and you spoke with her and you relied on what she told you, she still told you that she had anxiety, depression, a history of PTSD, current opioid use, right?
Yes.
Did you ask her about smoking?
Yes.
Did she tell you about smoking?
She told me that she smoked 2 to 3 cigarettes per day.
When you stated, let me skip to this subject about the knee replacement because, well, let's not, because you made a phone call to learn about her death and you spoke to what you understood to be her sister Kylie, right?
That was my understanding, yes.
Do you know when you made that call?
I don't remember exactly. I believe it was about 2 months after her surgery.
Okay, so you were interviewed at one point by the police, right?
Yes.
You remember it was 2 officers?
Yes.
And where did that occur?
In my office?
Do you remember the date?
Not exactly.
I'll tell you, it's January 27th, 2025.
Okay.
That would be after you talked to Kylie.
Several months after, yes.
In between, did you get any information about what happened to Kacee Terry from anybody except for Kylie?
I wouldn't say that I received much information from Kylie about what happened, and I didn't receive any information from anywhere else either.
So then when you had the interview with the police on the subject, they didn't talk to you about what Kylie had told you, right?
I'm sorry, I don't understand.
Well, you didn't have a discussion with the police about what you had learned from Kylie.
I think I reported to them that I had made a phone call to her, and I relayed to them what I have relayed to you guys so far here, that there was that she had passed away. I offered my condolences and that there was an investigation pursuing the cause of her death.
Right. Did you know that the meeting that you had with the police officers was recorded?
I believe they did say that.
Have you ever seen a copy of a transcript or heard a copy of the recorded?
No.
Touching on, to be clear, there was no plan for a second knee replacement for Kacee, right?
There was not an immediate plan. She was not on the schedule for that second knee replacement.
It had been discussed.
It had been discussed, yes.
Let me ask you this about something you said at the end. You said after talking to her sister, you conducted some sort of review. Is that what you said?
I would have gone back and looked at the chart and reviewed our records and seen if there was anything that I thought we had missed that might have put her at risk for some complication that might have resulted in her death.
Well, you knew that her death wasn't related to your surgery, right?
I mean, at the time, I didn't know anything. I had simply seen a report that there was a death within 90 days after my surgery, and that would be my natural response in any of those cases would be to go back and review the details of the chart.
Okay, and so you reviewed the chart that you had already created in the course of your treatment with her?
Yes.
You didn't do any other investigation?
No.
You didn't try to see whether, in fact, the things that she told you in that chart in the 45 minutes you met with her maybe weren't true?
I didn't go digging further, no.
You weren't asked to?
No.
One moment, if I could, Judge. known anyone who died by suicide?
I'm sorry?
Have you ever known anyone who died by suicide that you were close to?
I have.
You're aware, with whatever training you've had, that it's extraordinarily hard to know ahead of time sometimes that someone's suicidal. Can we agree on that?
It is.
Sometimes they commit suicide when nobody had any idea whatsoever that they were thinking about it, right?
Absolutely.
People commit suicide that have plans for the future, trips planned, right?
Yes.
That have
that is a
children.
possibility. Yes.
That shock the family when they learn that their loved one has committed suicide because they never saw it coming, right?
Yes.
That they act normal so they'll not be interdicted in their suicide efforts, right?
That is possible.
Thank you. I don't have any further.
Any follow-up from the state?
No, Your Honor, this witness can be released.
Thanks for being here.
Thank you.
You're free to go.
Okay.
We have Mr. Farnsworth available.
Yes.
And do you have any, does the state have any additional questions for Mr. Farnsworth?
No, I think we can turn him over for cross.
Thank you.
Can I just go get these for a second?
Of course.